Good morning, I'm Caroline Flint, Chair of Humber Trust, and we're with you a little bit later today because earlier we were listening to one of our patients' stories and it was incredible and overran, but it overran for very good reasons. So I'm apologising that we are late, but it was for a very, very good reason. So we're going to start our formal public board meeting today, and I'll start by taking apologies for absence. Are there any apologies for absence?
Dean Royals.
Yeah, Dean Royals, non-executive director, will be joining us a little later. And I'm also pleased to say that we have our new non-executive director, Stuart McKinnon-Evans, who's here officially. He started a short while ago as a new non-executive director and our audit chair. So welcome, Stuart.
Thank you very much. Good morning, everyone.
So, declaration of interest. Are there any declarations of interest people want to make? Everyone will know that if there is something on the agenda that causes any conflict, please let us know so you can remove yourself from that item. And any changes to your declarations, please let Jenny Jones know so she can update. So anything to say on that from anybody? No? OK, thank you very much. We'll move on to the minutes of the meeting held on the 26th of January 2022. Are there any corrections to those minutes? Everybody happy? OK, thank you very much. And we'll go on to the action log and matters arising. Any comments on those from anybody? Looking around. Francis, thank you.
Just one on the action log on pack page 24. It was that Lynn was going to send me some primary care data, which she has done. OK, thank you very much. We'll make sure that that is included. Thank you very much for Francis for that. Any other points anybody wants to make? No. Michelle, thank you.
Yeah, sorry, I just thought it is on the action log, but I just wanted to reiterate that the NED visits, obviously we've got the infection control guidance, thanks Hilary, that's been circulated, so we're just in the process of sending some dates out to non-exec directors and execs to do the visit, so they'll be starting towards the end of March, so thanks everybody for that. And obviously the staff, I think, are quite looking forward to seeing some people again officially, even though we've been popping in and out all the way through the last couple of years, but they're on the way.
Thanks very much, Michelle, for that update. If there are no other matters for the log or the minutes, can we receive both of those? Yes. Thank you. OK, we'll move then on to my report, Chair's report. Just a few highlights since we last met. It seems like 2 weeks ago we had the last board meeting, but that's February for you. So I had a chance to meet up with Sharon Nobbs and Val Higo to discuss volunteering within the trust, which was really helpful. We also had the Freedom to Speak Up quarterly meeting, and Peter was there as well as Michelle, along with Alison Flack and Nikki Titchener, the Guardians. That was a helpful meeting, but also what came out of that too was a sort of refresh for the strategy. So it was really great timing because I had a meeting with staff governors and both Alison and Nikki joined us for that session in which we could talk about how we could engage staff more in Freedom to Speak Up, and there were some useful ideas that came out of that. I also met Paddy McIntyre, the staff side rep, with Michelle, and again that was a really useful conversation with him about the trade unions within the organisation and how the staff side worked. We had a really, I think, positive governor induction session for new governors coming in, although there were a few existing governors who took part as well. Thanks to people on our meeting today who helped with that, but also some of the other governors, both staff and public governors, who shared their experiences with the new governors as well. I think it was well received, and thanks to everybody who helped make that work. On the ICS, I've had several meetings since last we met on the Integrated Care Partnership and what the membership of that will be like. We've had several meetings with Health and Wellbeing Board chairs, as well as the chair, Sue Symington, of the ICS. and colleagues, Councillor Michael Harrison and Karina Ellis. And I think we're making some progress. We're not quite there yet, but we are making some progress. So those really are the highlights from me in terms of my report. Any questions? No, thank you very much. We will move on then to Michelle Moran's Chief Executive report. Thank you.
Thanks, Chair. I agree. It just seems 2 minutes since we did have the last board meeting, but as you say, that's February for you. And what a month we've had weather-wise as well, particularly. There's just one item for approval today, which is the modern slavery statement. This is a statement that we make every year in relationship to our policies, procedures, procurement processes. I won't go through it, it's detailed in the paper. People have had a chance to have a look at it. I'd like that approving, if that's okay, at the end of the item. Lots in there as usual. I thank my colleagues as well. So still lots happening and lots going on around the organisation, but obviously still under pressures, which we've got the winter pressure and the COVID report in there. So just to pick out a couple of things, we have had some great conversations with our senior leaders and with the teams in relationship to priorities. Obviously, we've got a lot of continuing priorities, but we've picked out, as we always do, 10 of the key things that we need to really concentrate on alongside the plethora of other metrics and performance that we need to do. And what's been really positive over the last couple of years, particularly, is that we have continued with our transformation programme, our journey of quality, etc. So I'm not going to list the 10, they're in the paper for you. Still continues to be great work with the staff trainer. I think that's beginning to grow momentum, and lots of lifestyle management changes. We've mentioned that before, and that links into our health and wellbeing work. Lots of things in the report about primary care and research. Our research capacity continues to grow under Catherine Hart's leadership, declaring interest on part of the CRN. However, I think there's lots of work going on. I pulled out the primary care piece because it's quite unusual to see such a lot of elements in relationship to primary care. It was talked a little bit about the research conference that we had towards the end of last year, but I just thought it was really positive to demonstrate that. So thanks for all that work. And I know that John's report mentions research a little bit later on. There's a bit in there about zero events that Hilary, I'm sure, will want to pick up, and obviously our work on LGBT month, which February has been. Quite a bit about our capital expenditure programme, which is great. We spent a lot this year on capital, which is absolutely fantastic. And I don't know if Pete wants to pick up any of that. Communications have been busy alongside our general communications to staff. We've obviously continued with vaccination programme, the flu programme, etc. It's all contained in the report. And there's an update on the Whitby Hospital Appeal programme. I do want to add just one thing that's not in the report, if I may, Chair, and that's about an inquest that was a preliminary inquest hearing was heard yesterday, which is it's a high profile and a tragic case for us as an organisation, and that's the tragic death around Sally Mays, which happened on the 25th of July 2014. So predates the majority of the board. And as the board are aware, there's been several investigations, several inquiries into the tragic events that led up to Sally's death. If you remember, there was a High Court hearing a couple of months ago that wanted the inquest to look at a particular conversation. It happened in a car park. It's now referred to as the conversation. That opening was yesterday. No, sorry, apologies, it was Monday. The original inquest was in 2016, and that inquest will continue. We haven't got a date yet. We are continuing to support the staff, and obviously the issues that were there at the time have been embedded in the organisation, has been through several times. I'm going to stop there, Chair, but I just thought the board would want to just be aware of that, because it's obviously a very tragic but high profile case. I'll leave it there. I'll throw it open to my colleagues if they want to add anything from the team, and as usual, take questions and comments. Thank you. Pete.
Thanks, Michelle. So just a very quick update on capital. So it's 24 staff areas we've completed, not the 214 in the report. So apologies for the typo, but it's great that we're actually starting to see the bike sheds come in, and we'll start installing those next month. Really exciting year for capital this year. It's one of our biggest capital programmes, certainly since my time with the trust. We are rolling out electrical vehicle charging points across the rest of the estate, so that's good and supports our green plan agenda. We've got a contractor appointed for the backup generator at Avondale and Miranda House. And then just very quickly, you'll see a bit later in the report that there was some national slippage on the National Mental Health Dormitory programme. We put some applications in how we could utilise some of that slippage funding for the trust, and we've been successful on Freebridge, which is really good. It was similar to last year, so we've secured some funding for the remaining works at Maester Lodge and the staff wellbeing area, some support for the ward refurbishment works that is ongoing, and some ventilation works at Millview. So really positive that we've accessed that slippage. I'll stop there, Michelle.
Thanks, Pete. Are there any members of the executive team who'd like to add anything to the report before I bring in questions? Michelle Hughes.
Just quickly, Chair, just to highlight our intranet, that continues to be a major information source for our staff. And in just under 3 weeks since the last reported figures, our intranet platform has been visited over 165,000 times. The team have also now started the next phase of the intranet upgrade to add clinical teams directory. This will feature every clinical team and help the teams learn more about each other. The development of the intranet itself is just one aim, but the other is to continue to foster those working relationships and engagement between teams. Externally as well, progress against our marketing goals continue, and our external website continues to have good engagement with 14,000 in the last month, 12,000 new users, and 34 positive news stories published. So just to highlight that, the marketing and communications team remain an integral part of our service and strategy delivery. Thank you, Chair.
Thank you, Michelle. I don't see other members of the executive management team, so I'll go to Francis.
Thank you, Chair. And as ever, a really excellent and comprehensive report, so thanks very much. A couple of questions and a couple of comments. Really good to see the work on the primary care research. Really good to see that. It's excellent. On page 43, which is the mental health support teams in schools, I was just wondering, looks really good, and it says it covers 35 education settings. That's 35 out of how many? What kind of percentage is that covering?
Lynn,
yeah, sorry, Francis, I'd have to go back and check the position on that to be accurate. Rather than tell you what I think, I'd rather check. Okay. I'll let you know if that's okay outside of the meeting. It's a good proportion, I know that much.
Okay, thanks. On the severe mental illness annual health checks, really, again, looks really interesting. I just wondered, all of the issues raised about blood pressure, etc. I just wondered how that compares to the average population. It's obviously high. I just can't get my head around how that then compares against. If you looked at the average population rather than people with mental health issues, how does the two compare? I don't know if John could answer that.
It would depend on your age, Francis, and a whole load of factors. So 25-year-old fit, healthy people wouldn't normally have an annual blood pressure check, where somebody who has multiple conditions would do. And if you are on blood pressure medication, normally you would have a blood pressure check twice a year, particularly if you've got a long-term condition. So, you could compare that particular piece of data against hundreds of different particular metrics. What I would say, though, in terms of the SMI, you might remember, Francis, we talked about the Core 20 plus 5 approach to health inequalities, and this is one of the targets which sits in the +5 piece. And this is an example of actually where the organisation, dare I say it, is working differently through a different model to deliver some of that health inequalities agenda. Because it's been one of the challenges in primary care, not just the primary care that we run, but nationally, this is a well-established problem that people with SMI are not getting the health checks that we need for a whole set of reasons, but actually a different approach, such as we've modelled through health trainers, is the way ahead.
Thanks, John. That's helpful. Thanks. And then two other minor ones, just to say, again, well done on the medical education piece and the extra trainees. That looks really good and positive. And at some stage, it would be good to see the apprenticeship presentations, not necessarily at board, but just to see them, because they, again, sound really interesting. That's it. Thank you, Chair.
Thank you very much, Francis. Peter. Francis.
Okay, thanks, Caroline. Yeah, I enjoyed reading the report. Very comprehensive. Again, Michelle, thank you. Maybe a couple of questions. One is relates to changes to testing and self-isolation to COVID that the Prime Minister has been announcing. And I just wondered to what extent that that would affect staff and visitors to the premises beyond the end of March. That's one question. And one for Pete, I was just wondering, on Granville Court, it mentions about site valuation for purchase. Just to clarify what that is. Are we intending to purchase Granville Court? Perhaps just explain what that means.
Shall I pick up the COVID piece first, then obviously Hilary might want to come in. I mean, we've obviously, as usual, continue to keep abreast of what's happening nationally. For now, we put a couple of comments out already this week. There'll be no changes in relationship to our guidance, our restrictions in relationship to NHS staff, etc. So we're maintaining the status quo with masks, lateral flow testing, etc. And obviously we'll keep an eye on that. Especially there's been some conversation about whether the tests are going to be free or not free, and there's some issues about visit social care or health, so that will become clearer towards the end of the month. But at the moment we're just continuing with our same precautions and guidance, Peter. But I don't know if Hilary wants to add anything there at the moment.
Yeah, as we came into winter, we got some specific guidance around winter and infection control procedures that we needed to follow, and it was in the guidance to say till March those would sit in place. Obviously, all that predates the Prime Minister's when he said this week that everything will be stepping down, obviously, but we will stick to that until we get some further guidance as we go into the spring. But at the moment, business as usual in terms of PPE, etc., as Michelle says.
The other thing that we will continue to do for probably forever now, really, and based on the back of staff feedback, etc., is that blended approach to working from home and working in the office, and getting that balance between face-to-face meetings, face-to-face supervision, etc., etc., but also that working at home piece, which is part of the reason why we're doing the HQ bit as well, and obviously the HQ changes. But the feedback we've got from staff is that they actually quite like that, and it helps their work-life balance, etc. So I think I stood up 2.5 years ago and said that that's the agile working, because we were working towards it anyway. We wanted to do more agile working, we just didn't have the systems in place. We've got now, so we'll continue to do that. And I think people like the ICS are looking at the same thing as well, because of just the geographical patch that we've got. And I think it's helped bring the geographical patch that we cover a bit closer, because obviously what we used to say is that Whitney felt a bit disconnected from HQ, but obviously with Teams and with virtual, though it's not the panacea for everything, it makes that easier. So we'll continue that irrespective of the guidance going forward.
Thank you, Michelle. John, did you want to come back on one of the questions Peter made? John.
Yeah, Peter, look, it's a very helpful question. I'm sure, Peter, you will have spotted in the media that there is an awful lot of discomfort around some of the decisions with regard to this, between perhaps those of us from a clinical background and others. And I will avoid getting into too much contentious water there, if there are, to say the least. However, we at EMT are having constant discussions, because we're crystal clear that there's 3 things that we need to do going forward, if not this particular wave, certainly into the next wave. And we're already thinking about flu for next year. And that is focusing on PPE, vaccination and ventilation. And we are already having those conversations, because while we might at some stage in the near future have a little bit of downtime, I think our collective learning over the past years is that if something does reappear and it's more likely to be autumnal in nature, that we're good to go, and we can just dust down the plans we currently have, but perhaps build on 1 or 2 of the things that we haven't had, so that we're ready to go from next autumn. Because these diseases are clearly a disease of inpatient environments, and likewise they are worse when everyone is crowded indoors. So that's what we need to address going forward, Peter.
Thank you, John. Before I bring Mike in, Pete, did you have a comment to make on question from Peter Barron?
Yeah, it was just on the question on Granville, Caroline.
Okay, sorry, yes.
Yeah. So Pete will recall that at Finance Committee, we identified that we'd secured some resource, we had some resource available, that we were ring fencing for the capital works at Granville. As part of that, we were exploring whether or not it would make sense to purchase the property. Because obviously, if we're going to spend significant sum developing it, it would be more sensible to own the property. And we're just exploring with NHS the funding flows, because there's every opportunity that funding may actually materialise in a grant back to the trust to fund the purchase. So that will be next financial year, though, Peter.
That's great, thanks.
Thanks, Pete. Thanks, Peter. Mike.
I've got 2. On the physical health tests for SMI, impressive performance moving from 11 to 39.9%. Very difficult group, but if you looked at it just as figures, you'd think, well, 39.9%, is that really impressive? And I just wondered what our aspiration was there. So that's the first one. The second one is the Humber High Potential Development Scheme. Just wondering what that is and whether it's been accessed by our clinical workforce.
Thanks, Mike. Michelle?
I'll pass over to Steve for what was the first one, Mark? Or do you
It was the annual health checks for people with serious mental illness. We've gone from East Riding's gone from 11 to 39%, and I'm saying, what's the potential to get that up to somewhere where you might think, well, oh, it's 90 or whatever.
Okay, I think.
Yeah, John will come in, but what I was going to ask, obviously John mentioned something earlier on about SMIs, and I think there's a question on blood pressure. We've put a lot of money in through the system, through the integrated care system, because we were a real outlier across the patch, not just Humber and North Yorkshire, New York, but the whole piece. Part of that was the data collection, because obviously it's done in primary care. So the data collection was part of the issue. It was not the sole issue, and people recording it and how it was being recorded. So Stella Morris, who works with the integrated care system team, led a piece of work, and we managed to get quite a bit of funding to start to do the interface between the digital platforms, but also to look at how people were recording it, but actually how GPs were doing it as well. So that's been part of the reason for the uplift. We want to get higher because, as we know, we've talked about health inequalities. We talk about the difference between, the modality that John referred to earlier on. So actually, I've set a target in the ICS as 85%. So it is a bit higher than the national one, but we'll continue to keep going. But so that's part of the reason why. I know we've done some work internally as well, but I know John wants to come in. The other thing, the high potential scheme, absolutely, yes, we're all over it, and I'm sure Steve wants to just go through a little bit about that, because it's a great project that we're working through. But I don't know if John wants to add anything else about the SMI checks.
So yes, please, Michelle, thank you for that. And as you say, the ICS is targeting and investing in it. Mike, like a lot of things, the responsibility for delivering these health checks, not just SMI, actually sit within primary care. And we've had problems over. These are not new checks. They've been in existence for a while. Likewise, with our learning disability physical health checks, there's always been, even though there's been incentives for primary care to do them, they haven't necessarily either had the opportunity to do them or been able to take them up. So look, I think this is just a way of thinking differently and thinking about using different skill sets differently to engage vulnerable cohorts. And this could just apply to somebody with a cardiac condition or a respiratory condition as much as it does too with an SMI. And it's the whole idea of using health trainers with those different social prescribing skills to just move this away from a medical model into perhaps a more holistic model. So Michelle has set an ambitious target of 85%. My personal view is that, a bit like diabetes, everyone should have 100% of these checks done, because we know there is an age gap in terms of mortality of about 15 to 20 years, depending on where you live, for people with SMIs. So it's absolutely crucial, because most of these people will have comorbidities, high rates of smoking and other substances as well. So, it's really key, Mike, that we support primary care to do this differently going forward. And I'd be optimistic about this approach with health trainers, that we've got the model there and we know it works.
Thank you for that, John. It is interesting, though, that the patients themselves preferred it coming from a GP surgery rather than other community venues, and that's almost, sometimes we think it's always not going to be the case, but actually in this case, for this group of people, that has been the take up has clearly made a difference when it's offered from that venue. So I think that's a really interesting insight into this as well. Before we go on to Mike's next point about the Humber High Potential Development Scheme, did you want to add something more, Lynn? I saw your hand up. As your hand's gone down now.
Yeah, I think my points have been raised, Caroline, but obviously I think the benefit that we're seeing here, as John's suggested, is that we've got specified capacity in the health trainers team in order to carry this out, and that is the step change compared to it being delivered as a routine by primary care. I think the point that you make, it's not quite what we expected, but I think there is something very much, and it will come out through the further sort of pilot work and the evaluation as well, around patients' preference for this, that GP practices are probably a less stigmatising environment than some of our other facilities, but that needs exploring a little bit more. So, and in terms of your point, Mike, about the target and do we aspire for more, for the reasons that others have said, we absolutely do. And, you know, I think we will see quite a significant improvement before the pilot completes by the end of March as well.
Okay, so I think, are we going to go on to Steve to answer Mike's second question, which was about the Humber High Potential Development Scheme?
Thanks, Caroline, and thanks for the question, Mike. Yeah, so the Humber High Potential Development Scheme, part of the PROUD programme that we put in, we ran it for the first time last year, where we looked to identify 10 candidates to be part of the programme. It's targeted, Mike, at our bands 2 to 7, and also sort of positive action with regards to underrepresented groups. So if you're lucky enough to get on the programme, you get a dedicated training budget, you get support, you get mentoring, you work on some projects, and you get that kind of dedicated learning time. So the idea being that we're investing in clinical staff, certainly, that are at that stage in their career at the beginning, and aspire to move on and move upwards. So first year, last year, fantastic. We're really pleased to have 40 applicants for the second. We've just got those selected down now, so they'll be sort of signed off this week, and we actually have the celebration event for the first year next week, which Caroline and Michelle are kind of co-hosting for that, so it'll be really good. So, you know, in difficult times, as we all recognise in COVID, to still keep that going, to have done it last year and to continue, I think it's a real credit, and it's been really well received. So yeah, thanks for the question, Mike.
Thanks, Steve. Thanks for the question, Mike. Stuart.
Thanks very much, Chair. My question, I think, is probably for you, Lynn. It's about the recent review of the arrangements for the mental health and learning disability services in Hull. The report clearly sets out kind of what stage we're at and what's being discussed. The question is, how are discussions going about the implementation of that decision?
I think, Stuart, discussions between ourselves and the council are generally going well as it stands at the moment. We have started, obviously, the formal consultation process with the staff, the learning disability social workers affected by the change. And I think, as I've said previously, those social workers are dedicated social workers. They've worked very hard, particularly around the integration agenda. So they are disappointed with the outcome of this review. However, the council have made it with some sort of factual context that we understand too, and they would be the same issues that we would be facing for the future. So, you know, we understand as an organisation the position that the council are taking, but obviously we're disappointed for those staff affected, Stuart, and any change process of this nature, you know, no matter how well it's managed, you know, is unsettling to say the very least. So we are supporting our staff, as you would expect, as well as we can through this process.
Yeah, that's good to hear, Lynn. Thanks for that. And I guess it's a kind of a case study in how we make a cross-organisation system work, which will definitely be a feature of things in ahead, won't it? So thank you for that. Yeah. Thank you.
Thanks, Lynn. Thanks, Stuart. If there are no other questions, I can't see any other hands raised. Can we first of all approve the modern day slavery statement? Is everybody in agreement with that? Thank you so much. And then if we could note the Chief Exec's report, but could we put in the action log? I think one of the issues Francis raised it about us looking at having some sort of presentation on the apprenticeship provision that's provided, and we can look into what forum that might be best to provide. I think that's what you wanted, Francis, wasn't
it? It was to see there's 2 videos, I think, being made that looked interesting. Yeah.
Yeah, we'll take that away as part of the action log to follow up and find the best way to deliver that. So thank you very much. Moving on, then we go on to the publications and highlights report. Michelle?
Yeah, thanks, Chair. Again, I won't go through this. It's there. We've pulled out all the relevant publications that happened over the last 3 weeks with the relevant director lead and what we're doing with them in relationship to the organisation. So I'll just open it to questions, Caroline.
Thank you very much. Are there any questions from anybody? No, everybody is happy with that. Can that be received and noted? Yes. Moving on then, we get to the performance report. Pete.
Thanks, Caroline. So this is the usual format report, takes us to the end of January, so the month 10 performance. We've included the narrative within the front cover, but I'll highlight a few areas and then hand over to Lynn on weighted time before we move to questions, if I may. So you'll note within the safer staffing dashboard, if I can even say it, that fill rates are low. However, the level of care hours per patient day still remain above threshold, which is what we talked about at last month's board. You'll also notice that the level of sickness remains high across most wards. I think it's important to note on that the dashboard is at December, and you'll see in the wider IBR that our sickness continued to go up in January. So I'd expect that to be a feature of next month's report. And we've included within the narrative of the report some of the offers we're putting out there to help alleviate some of the pressures sickness is causing. A couple of other areas I'd pull out before we move to questions. So for IAPT, we're maintaining the 18-week position, but due to the levels of sickness, we are seeing a bit of an impact on 6 weeks performance. But not just focusing on the areas for improvement, there are a couple of positives we can pull out of the report today. So great to see the improved position for out of area beds, particularly given the environment we've operated in for the last probably 3 months. And also ending on a positive, we've seen improvement in the care programme approach or CPA reviews as a result of the recovery plan we put in place. So I'll stop there. I'll bring Lynn in now just to talk a little bit about waiting times before we move to questions, if I may.
Thanks, Pete. Lynn?
Yes, thank you, Caroline. Thanks, Pete. So the overall position on over 52-week waiting times, as the report describes, is still continuing to improve, which is good. I just wanted to touch specifically on the children's autism spectrum diagnosis waiting times, which we've been focusing on as a board and certainly operationally for some while now. I did include the latest trajectory for both Hull and East Riding in the winter pressures report last month, but just to provide an update in relation to that. So on the Hull trajectory, that continues to remain on track. It's on trajectory. So the numbers now waiting over 52 weeks are 557, which is still much higher than we would want it to be, but it actually is an overall reduction of around 200 waits over the last year. So it has reduced by 200 cases, which is good. We're doing everything we can still to hasten that improvement. So with the additional resource that we've put in place recently and have had for some while. The position on the East Riding waiting times for those children has improved further as well. It's 41 young people waiting over 52 weeks. So that is an improvement. It's not quite back on trajectory, but it's certainly going in the right direction. So that overall waiting time that was 2 years, 12 months ago is 14 months now. Still not where we want it to be. And our plan obviously is to eradicate those over 52-week waits over the next couple of months. But very happy to take any questions on that.
Thanks, Lynn, for that extra detail. Appreciate that. Mike.
Thanks, Lynn. Apologies if you answered this because my sound broke up in the middle of it, but it looked a mixed picture to me from pages 80, 81 and 82 in the report, where when you look at ASD, you can see positive improvement. When you look at page 80, number of patients waiting 52 weeks for treatment, excluding ASD, it's extremely high and dropping in a month, but actually the trend line is still pretty much up, and I just wondered where we are and what classes of patients are within that group.
Good question, Mike, and as I've been reporting here before, that's predominantly core CAMS and ADHD. And as the report says, from next month onwards, I think it'll help us operationally and help me describe the position more precisely here at board. We are extracting the ADHD waiting times from the core CAMS waiting times. So I'll be able to tell you, as in what I have done here before, what work was specifically taken to address that.
Mike, did you want to come back on that, or?
No, that's great. Thank you.
Thank you, Mike. Peter?
Thanks, Caroline. Yeah, just on page 72, then the dashboard. I think, given it's December and given that the sickness levels were high, I think the indicators for each of the units a lot better than I thought they'd be, and the occupancy has been high as well. So I think that's really well done to the teams there for those achievements. Just a couple of minor queries, I guess. So Inspire, during the day, the staffing levels are down at 52% and 78% for registered and unregistered nurses, which seemed a little bit low. Perhaps comment on that and how that's maybe been corrected since. And also on Granville Court, there's a couple of items where it's not applicable or not available, rather, for occupancy and clinical hours per patient per day. I just wondered, why they would be blank at that stage, and perhaps give us some assurance that those figures are okay.
Who'd like to come on that? Is that Hilary or is that Lynn?
I can certainly pick up on some of that. Taking the Granville Court, obviously that's a residential home, and I don't think we've previously reported on care hours per patient day there. No. We can look at it, see whether or not that's something we can pull through for Granville Court, so that we get the completeness on the dashboard. And I think the same for occupied bed days as well, is it, Pete?
It's the fact that they're not on our clinical systems, are they, Hilary? So we can't report that activity. Yeah. But your care hours per patient day would be high given the patient cohort, and they're generally on a 2-to-1, aren't they?
Yeah. Oh yes. Yeah. But I say I can look into that and see whether or not we can pull something else through to give the assurances around Granville Court as well. On Inspire, where it's dropping, occupancy, although it's showing 92% there, it wasn't fully occupied, was it, Lynn? We're still not fully occupied there, and some of that is where we should have had 2 RNs on. There's one which immediately drops it down to 50%, but then there's other staff that are coming as well that aren't always pulled through. So some senior staff wouldn't be on the roster and they're not getting pulled through, and that is how we've managed to get through December. Really, you've got to remember in December we had Delta and Omicron was starting to come through as well. Lots of sickness, so it was just a daily thing, wasn't it, Lynn, of trying to cover these units. So we were often covering them with people that we couldn't then pull through on the roster. So that's why it looks like it does. And I think the only thing that gives you the assurance that they were safely staffed is Peter's first point, which is care hours per patient day remained good. The indicators, you can see that they're flagging. There's a lot more red on there with the sickness, and clinical supervision as well has been impacted because the staff just weren't there to do the clinical supervision. They were off sick. So all of those, barring one, are starting to improve, I've seen in January, although pressures were still significant in January. So I think that's very positive as well, that staff are still bought into doing clinical supervision and see it as a priority, because you can see that it's moving up. Still not quite compliant for the ones that were red, but they're going in the right direction. The one again that's of concern is ILS and BLS. They're started to flag a lot more red on there. Again, staff were not there to be trained, they were off sick. So I've asked for a trajectory there from the trainer for that to get these units back on track as we go forward as well. Does that answer your question, Peter? Thank you.
Thanks, Hilary. John, did you want to add something there?
Yeah, I just want to reiterate the context to the board of what happened with Omicron from about the 10th of December. And the borderline overwhelming spread of it right throughout the UK. And we weren't immune to that. And actually, I think just about being able to keep proactively the show on the road in terms of staffing, lots of agency was brought in by Lynn just to bolster the numbers. But it was almost the first time in 2 years that from our perspective, because of the transmissibility of the disease, that we felt it was becoming very, very difficult and that we managed to keep things safe. So that's why I think you will look at the December data and probably January data, and we're still seeing a tail of this, Peter, in February in terms of staffing, because the key thing to remember is that we've kept high levels of infection control procedures in place. We've kept strict adherence to contact tracing and guidance in terms of keeping people away from work if there's any suggestion that it's not safe for them to do so. And one of the penalties for that is you see a drop off in performance. But the reality is it reduces the risk of nosocomial infections, not just in our inpatient settings, but also exposing our staff to unnecessary infections, and particularly the sequelae of long COVID, which I think we're going to see down the line. Hope that helps.
Thank you, John. And Lynn?
Yes, just to add to what Hilary and John have already said, as a consequence, obviously, of the pressures that we've been experiencing through winter, including Omicron and Delta, obviously, I have senior oversight, personal oversight, as a minimum of 3 times a week across all of the areas in terms of their inpatient safer staffing. Hilary joins me once a week where we review that together. That means that we really have that, you know, real as you would say, quite forensic understanding of what's happening in each area, almost on a shift by shift basis. And we'll continue to do that whilst we need to.
Thank you, Lynn. Are there any other questions? No. Can I just add to make sure everyone is aware that on the issue around waiting times that has been picked up on today, the board have requested, and it is ongoing, quarterly reports on that issue. So as well as obviously an update within this monthly performance report, we'll be scheduled in the not too distant future for a quarterly report, which we can have more detail on as well. And that's part of an ongoing piece of work for us to keep our eye on this area, which obviously everyone's working very hard on, but also still raises some concerns. So if everybody is happy with that, we'll move on to the finance report. Pete.
Thanks, Caroline. So again, finance report as at the end of January. As I always do, and I make no apologies for this, just continue to remind the board that for the remainder of this year, we operate under a block funding arrangement, and that our planning target for the year is to achieve a break-even position by the end of the financial year. So in terms of our monthly and overall financial position, at the end of January, we remain on plan and we recorded a year-to-date surplus of 153,000. And that's a continuation of the unwinding of the surplus we developed in the first half of the year, and would continue to unwind that till we get to break even by the end of March. You'll see from the report there are a number of items that do fall outside our control total. We've talked about these before, but when we include those, our actual ledger position is a 3.1 million surplus, and that is predominantly the Yorkshire and Humber Care record funding, which is supporting the capital programme. I guess other quick key highlights to pull out before we move to questions. So our COVID related expenditure and top up funding total 6.2 million at month 10, and that sits within the envelope of funding we've been allocated. Primary care continues to be an area of pressure. We had a long conversation at Finance and Investment Committee, and myself and Lynn are working on a recovery improvement trajectories for the next meeting. You know, cash remains strong, which is great to know. As always, we now include an estimate of the timing difference for the cash we're holding for the provider collaborative. And you can see agency spend year on year has increased, but given the conversation we've just been having on sickness, there are no surprises there. I think what I'd summarise is I think we remain in a strong financial position for this year, and I'll stop there and happy to take any questions.
Thank you, Pete. Any questions, please? Francis.
Just a quick one. Pete did pick up on it. Just looking at it, obviously primary care must have worsened since last month, because if you compare performance this month to last month, it's about 200,000 worse. But I think I just wondered if you wanted to expand on that at all, Pete.
Yeah, primary care continues to, I'm going to use the word, a financial challenge, Francis. I mean, it's predominantly the use of locums, and we are working on a recovery plan, and it is centred around a couple of practices generally. We've got high levels of sickness at P2, which is a practice we only recently took on board, and obviously Market Wheatham. And I don't know if there's anything you wanted to add to support that, Lynn.
Yes, thanks, Pete. As you say, you and I are working on the financial recovery plan. There is some feasibilities around improvement, Francis. We are in the process. We've interviewed 2 potential substantive GPs in the last week or so. So obviously, if those come to fruition and the view at the moment is that they probably will, then actually that does have quite a significant impact on the locum use as it stands at the moment. But Pete and I will obviously bring that forward through ENT into that recovery plan, and obviously that recovery plan will come to next Finance and Investment Committee.
Thank you, Lynn. Thank you, Pete. Peter Barron.
Yeah, thanks, Caroline. Peter, I don't know if you just want to comment on the operating plan for 22-23, because in previous years, I guess we've seen a draft by now, but the various reasons why we haven't seen that, and perhaps say what the plan is, you know, for the board seeing that before the end of March.
Yeah, of course I will, Peter. So we are in the midst of the planning round at the moment. So you're absolutely right. Ordinarily, we'd be bringing today a draft operational financial plan for the next financial year. Unfortunately, we're not there yet, and the main influencing factor is the move away from the block funding regime to signed contracts between providers and commissioners. So I guess sitting here today, you know, and I don't mean this to sound arrogant, but I could probably tell you what the level of funding we need as an organisation based on what is our current cost base, what is the full year effective investments made, and what have we prioritised as investments as an exec team based on numerous factors, environment, staff survey results, et al. What I can't sit and tell you at the moment is what's the level of funding we're going to get from the ICB, because that is in the process of negotiation. So at the moment, draft funding envelopes were issued this week. There's emails floating around on my computer today where they're getting nudged and queries are being made. So I guess the intention would be that we'll go through the governance of EMT, and then for next month's board would bring a draft financial plan, noting that draft plans get submitted in March and final plans get submitted at the end of April.
Thank you, Pete, for that. Any other questions on the finance report? No? Okay, oh, sorry, Stuart.
Sorry, late hand going up there. Couple of commentary. I think the combination of the performance report on staffing levels and the financial expenditure assessment of spend on pay probably gives us cause for concern about the which I think links to the 22-23 planning priority of staff recruitment. I've had a conversation outside the meeting with Steve and Pete about what other employers are doing to retain, attract staff. So I think there's an issue here, isn't it, about whether we've got our pay offer right. It seems to me it's not for answering today, but I think to take into our planning forward. And I think as a newcomer coming in, it's a really great report. Cash balance figure is helpful to some extent, but I think maybe it's one for Francis and I to pick up in the finance committee again about the whole issue about cash flow forecasting is also a useful tool for the board to look at. But I'll pick that up outside the meeting, I think.
Thank you, Stuart. Thanks. Okay, fine. Then if there's no other questions, then is that received and noted? Yes, great. Now we have Alison Flack, who's been waiting. We've obviously run a bit over time from the patient story earlier. So can I suggest that we take item 15 as we have Alison with us and then come back to the Assurance Committee reports? Is that okay with everybody? Great, lovely. Sorry to put you on the... Pardon?
What page in the pack?
128.
Hang on.
128.
Thank you. I should have asked Francis in the first instance.
Francis 128 Francis.
Thank you. Okay, Alison, welcome. If you'd like to introduce item number 15, please, the collaborative programme update.
Thank you, Caroline, and morning, everybody, and just morning to Stuart, because I think I know all of the board, but I don't think we've met before, so nice to meet you, Stuart. I'm the programme director for the Humber Coast and Vale ICS Mental Health, Learning Disability and Autism programme. So I've just come along to give an update, and you'll see from the report there's an awful lot going on across the programme, and it was quite helpful to join a bit earlier because it was good to hear the discussions about the SMI physical health checks and what's going on with the work that we're doing on waiting lists across the system. And I think from just some of the data that we've captured, Humber have done an awful lot of work in that area. So it's good to see that we're joining up with everything. I'll just take you through just some of the highlights, some of the things that I want to pull out, because I know that you will have looked at the report and then take any questions. As Pete just gave an update, we are in the midst of planning, and we are pulling that together across the system. So looking at finance, activity and workforce and recovery plans, how we recover against the long-term plan trajectory. So there's lots of work going on at individual place basis, working with with mental health providers that will then accumulate in an ICS planned submission. So that's the work that's going on at the moment. We have identified 3 priorities that we're going to focus on, again, which aligns with the plans that you've talked about. So out of areas, crisis services and children and young people. So there's a lot of work going on in that area. I just wanted to touch on the safe and wellbeing reviews. This is a national programme of work for learning disability patients who are in hospital, and we have had to set up assurance panels. So every individual that's in a hospital has been reviewed very recently by a case manager and then brought to a senior assurance panel that's made up of very senior clinicians, experts by experience, and others to review every individual patient to make sure that there's a level of assurance about them being safe and well, but also that there's future plans in place for them and any concerns are picked up as part of that. We are on track. The deadline to complete this is by the end of February, and I'm pleased to say that we're on track to complete that. We will have reviewed, I think, 64 patients in total, and I think it's been a really good process because it's brought clinicians together from right across the ICS, and there's been some really good practice and things that have been shared. There's also been a set of common themes where we need to do better. So I think although we've had this process, there will be more to come. We are expecting more national guidance, but we've also set a plan in place for our ICS to look at these themes and what we need to do in relation to it. The integrated care framework for children and young people, this is also referred to as the health and justice bid, and this is to support young people to prevent them really in entering the criminal justice system. So we've got 3 test and learn pilot sites across our 6 places, and we're just at the stage of developing our mobilisation plans ready to implement that from the 1st of April. This is a 10-year programme, so it's a long programme. We've got funding supported for the next 3 years, and we're just recruiting into those posts. Other highlights, just to touch on the right care, right person, which I know the board have discussed, and the work that's in partnership with Humberside Police. We are just awaiting the evaluation of that pilot, which has been ongoing since the 1st of November. And there's obviously ongoing work that we need to do, and we need to feed that into the planning process, particularly where there's some financial challenges. And we're also looking at developing a street triage model with Humber for residents of Hull, and we'll be looking at doing that in partnership with Yorkshire Ambulance Service. As we've touched on, we've seen, which is really good, but we need to do better, an increase in the SMI physical health checks, and this is as a result of the work that's going on between the trust and primary care, but also the additional devices, physical health check kind of devices that have been purchased to help to support staff working in the community. Work is ongoing. Really, we're just at the start of our work around health inequalities, and we've got Dr. Lucy Chiddick in our team working on that, and sort of we've just received the population health data, which will help to focus our efforts and where we really need to be prioritising. Trauma informed work, we've just had confirmation from the exec group that we're able to recruit to an additional senior post to take this work forward, not just within our programme but right across the collaborative. And great news that we've had the funding confirmed for the Resilience Hub that supports all of our staff's health and wellbeing, and is doing a great job there. And finally, just to mention that we've been shortlisted for the Health Service Journal Award, Partnership Award, for the work on the Together service, which is supporting those families bereaved by suicide. So that's really good news as a partnership award, and we look forward to hearing the results of that. So it's a whistle-stop tour, and happy to take any questions.
Thanks very much, Alison. That's great, and we can think about as a board about this new information on health inequalities stats, and how we can sort of have a chance to have a presentation on that, and maybe hear from Dr. Lucy Chiddick as well on her work. That would be great in the future too. So any questions for anybody? Hanif?
No, that was it, Chair. It was just the same point in terms of following up that detailed health information on the health inequalities, and if that could be elaborated upon at a future meeting. So thank you.
Thanks, Hanif. Anybody else got any questions? No? Okay, thank you, Alison, for that update, and congratulations. Please pass that back on the nomination. Great, that's really great. Thanks very much, Alison.
I think Michelle might.
Oh, sorry, I've got Michelle there. Michelle.
No, I was just going to say thanks, Alison, for a really good presentation and for all your work as well. There's a lot happening. So no, thank you. And we will do the health inequalities piece as well. That's really important.
Thank you. Thanks, Michelle. Thanks, Caroline. Thank you. Bye.
Bye, Alison.
Okay, we move back now to page 106. Work that out to item number 11, Mental Health Legislation Committee Assurance Report. Mike, over to you.
Okay, thank you, Caroline. I have that page number noted down in my note preparation. There's a good theme through the Mental Health Legislation Committee, because we received the Reducing Restrictive Interventions report at the same time as we considered the Mental Health Act Use of Force Act. And there's some really proactive work taking place there. We've had problems because of COVID with the training on de-escalation management and positive engagement, but a new venue is being found and we're in catch-up mode. And I think that proactivity really shows in that we're a positive outlier and have been for some time in terms of reducing restrictive interventions. From memory as well, I think we also reported 0 Section 4 applications, which is where we can't get hold of on-call doctors, which is really excellent. The other thing that we did was a deep dive into the analysis of ethnicity. We're still some way to go there because of the statistical makeup of the population in Hull and East Riding. But Kwame Fofe is leading on that, and we're going to try and do a bit more digging in terms of the actual ethnic population split, particularly looking at Eastern Europeans. So again, a proactivity there, not just the tick box of we've looked at ethnicity, but trying to understand it. And I think the other thing of note is that we had 3 attendees, I think, at this meeting. We had Sue Corden from the Well-Led Review. We had Yinka, who is Chair of Mental Health Legislation at Sheffield Health and Social Care. And John also brought along the GP lead. So we've done both some knowledge sharing and also some external benchmarking as to the work that we're doing. So I think we had a good meeting, but no room for complacency.
Thanks very much, Mike. Any questions to Mike? Comments? No, that was full, Mike. Thank you very much, and for highlighting those points. So are we happy to receive and note the assurance report from Mental Health Ledge? Thank you very much indeed. Moving then on to the Audit Committee Assurance Report. This may be the last time, I think it will be the last time that Peter presents this. Over to you, Peter.
Okay, thanks, Caroline. I did chair this meeting. I'm going to sort of stand aside a little bit for Stuart to make some comments, really, but it was the meeting on the 8th of February. I think it mentions the 9th of November somewhere in there, but it was 8th of February meeting. It was a good meeting. I think the internal auditors have really settled in well after just over a year and have made some good progress. We've had some more reports there on disciplinary and grievance procedures, budget reduction strategy, which have got significant assurance, and an advisory exercise that was done on email phishing, which there's some learning from. So that was interesting. I would say we're possibly a little bit behind in agreeing for the 22-23 internal audit plan, but hopefully, by email we'll get something by the end of March, if not sooner, once EMT have had a good look through that. So nothing really to worry about there, I don't think. I think it'll still be there on time for the 1st of April. The external auditors were there, gave their update and their planning for next year, which seemed in line with most of the years. We had a good presentation from the procurement manager, good discussion with the director from LD and Children's division on risks, which was very proactive. and we had a discussion as well on insurance, which you will note from my notes there that there's quite a big rise in the clinical negligence insurance for next year, 30% rise, which equates to 190,000. So we're going to have to plan for that within the figures. Other than that, yeah, it's a good meeting, and perhaps ask Stuart to maybe comment on his thoughts.
Yeah, thanks very much, Peter. Yeah, I agree. It was a very good meeting in terms of the kind of the depth of the coverage I felt on all the items. Just two things to add from my perspective. One is just there's a little bit of uncertainty at the time about the timing of the year-end processes. That's now been, into the year-end accounting process, that's now been clarified, which is good. And I think the other fact for me is that there's a change of personnel in the internal audit team coming in, so that shouldn't be a problem, I don't think. But it's always good, I think, to have someone coming in new with a fresh pair of eyes, but you have the slight discontinuity of them having to get to understand us a little bit. But there's no concerns on that for me. It's just something to watch. Very, very interesting discussion about counter fraud activity and the number of staff who, despite many kind of be alert to things during, I think it was the Black Friday week, did nevertheless kind of almost sign up to a phishing deal. So it's just one of those things that we need to keep working on, and it's amazing how people need to keep reminding to play safe. So thank you, Peter, for pulling the report together. There's nothing more from me. Thank you.
Yeah, thanks, Stuart.
Thanks, Peter. Thanks, Stuart. Any comments on this report? John?
Thanks, Chair. I'm just interested, Stuart and Peter, on the conversations with regard to cyber security. And I think, Stuart, you talked about the phishing exercise with relation to fraud, but actually I think the learning has been from all of these major attacks, actually, it more likely presents a risk or damage to the system. So I'm just wondering, did you see that link? As we talk about our IG governance is over 95% in terms of people doing the online training, but any personal reflections or observations on that?
Just for me, John, we didn't have a full. The digital plan comes back to us, and the cybersecurity reports on cause comes back to us 6 monthly. So that was due in the next audit meeting. So we didn't have a deep dive, particularly on that area in this particular meeting, except we did get the report from the group that oversees that. So that's about as far as it went in this particular meeting. But I would just say you can never have too much training, and you can never have too much work done by internal auditors. There's always going to be people make personal mistakes and whatever. So I think we've all got to keep the message going, keep the comms going, and just be as vigilant as we can, and keep the systems up to date with all the patches and things like that that the IT department do. But I know Peter's got his hand up. Say a bit more about this.
Pete?
Yeah, thanks, Caroline. Thanks, Peter. I think just to add to what Peter said, really, when we was in the audit committee, we did ask about the phishing email, and it was reassuring that we had to actually let it through our firewall for us to run the test. So had that email been sent from external to the organisation, it wouldn't have gone out. So we had to actually allow it through to allow the test to happen. And then very quickly, we did actually look at the IG training compliance, John, as you'd expect. For those that did put the details in, and about 90% of them were IG compliant. So there is now a targeted comms campaign for those individuals, and I don't think the email's gone yet. I'll have to check because I've been on leave, but it will be going very shortly to notify those that put their details in when they shouldn't have done.
Thanks, Pete. Thanks for that question, John. If there's no other questions, and I cannot see anybody, can we receive and note the Audit Committee Assurance Report and move on to the Quality Committee Assurance Report? Mike.
Thank you, Chair. As people may be aware, I'm interim chair of the Quality Committee, and I have been a member of the Quality Committee previous to that. But it's really interesting to see the connections between the two committees that ran over 2 consecutive days, because one of the things that came through with the Learning from Deaths report, for example, was about the quality implications of the 20-year gap between life expectancy for someone with a learning disability and the general population. The figure being on that survey, average life expectancy LD 58.4 years, countrywide average over 80, just over 80, so it's quite stark. But what was coming through there was, in the quality sense, some really practical things that in the previous survey, the year before, 40% of deaths were due to pneumonia, sometimes bacterial, sometimes to do with aspiration. And the learning from that report is about how to educate people, particularly in terms of aspiration, so that you can actually hit off at the pass some of these things. So it was very interesting to see not just a bold report that says, well, this is the statistics, we need to do something, but some practical stuff as well. The other thing that was considered at the committee that was mental health related was ligatures. And there's been a deep dive in terms of ligatures by the use of doors, and it's been a continuing problem, and there is no silver bullet. Some trusts have gone in the direction of technical solutions, others have done a blended approach of technical solutions and staff training. Some are still reliant on staff training, but a significant piece of work has been done. It's not come to a conclusion. It's come to the Quality Committee. There's been live issues that are being discussed. So what I'm seeing is the Mental Health Legislation Committee doing the compliance stuff and trying to dip its toe a little bit into quality, but the Quality Committee actually picking up the reins and running with what quality improvements can we get to actually make sure that we don't only comply with the Mental Health Act, but we can give the best possible patient care.
Thank you very much, Mike. Any questions to Mike on the assurance report or the minutes? No. OK, they are received and noted. Thank you very much, Mike. Moving on to item 14, collaborative committee assurance report. Peter.
OK, thanks, Caroline. This meeting was on the 21st of January, so it was actually just before the last board. So I think I did mention one or two things at the last board meeting, which pulled out a couple of things from this meeting already. So I won't dwell too much. But the team are working really well on quality assurance and improvement. We had work stream updates from the 3 work streams as usual, and there's a lot of proactive work going on there. The contracting all seems to be going well, and I think the board last month had a contracting paper which was approved, and the finances are all in line with the finances that we anticipated when we set off on this project before October. So everything is in line. There are pressures. I mean, there's particular pressures in the CAMS. I think at the end of January there were 9 young people, mainly eating disorders, waiting for beds. So you think that's a lot of bed capacity required in that area, and although they are actively managed whilst they're still at home or in their usual environment, then obviously that is a risk which is quite high, higher than we would like, and obviously that's something which the team are actively managed to try and get those young people receive the attention from the NHS that they require and deserve. On the adult secure, there are risks there as well, but I think one of the main issues is probably the fact that we've had some delayed discharges. I mean, the team have been working really hard on this, but I think there were still 9 delayed discharges, so that's beds which could have been freed up had there been placements available within the community for those people. So that's another area that the team are very diligently working on. So everything else I think is in the report. So I'll stop there and ask for questions or comments.
Thank you, Peter. Any questions or comments? No, I think therefore we can receive and note that report. Thank you very much, Peter. We've already done item 15, so we'll move on to item 16. Any items for escalation? Nope. Okay, then we move on to any other business, and I have one item of any other business which you should have the paper for on the Senior Independent Director role. I am recommending to the board, because it is for board approval, that Francis Patton becomes our new Senior Independent Director. I have consulted obviously with Michelle and also consulted with governors, and the response I've received has been supportive. You'll be pleased to know, Francis, and I would just like the board to approve Francis Patton as our new Senior Independent Director with an additional allowance of £2,000 a year. Can I seek is their approval for that report? Thank you very much. Congratulations, Francis, and you're still with us for a while, Peter, but just to put on the record here, thank you very much for your excellent role as our Senior Independent Director, and for the support and guidance and advice you've given to me in my 4 months, I think we're coming up to, or just beyond, that I've been with the Trust. And I think we all want to say thank you very much for the role you've played and what you've brought to this role, Peter.
It's been my pleasure, Caroline. Thank you very much, boss. I've still got another month, so the speeches can come next time.
It's going to be a long farewell. Thanks very much. Thanks very much, everybody. If there's no any other business, we will be concluding the public board. For those of you who are watching us, or if you're screening in at a later time, I hope you found it interesting, and we might see you again. So I formally close the public board meeting. Thank you.